Here is a case of right partial Staghorn calculus, right ECIRS. 55-year-old female patient with bilateral loin pain 1 month. On evaluation, bilateral stones, right partial Staghorn and left pelvic calculus. In this case, actually it is not very uncommon, routinely done cases, but we want to share that when there is a burden in the lower calyx as well as the upper calyx, the role of the supine PCL and ECIRS we wanted to share. This is a standard position. Naturally, the inferior calyceal puncture is preferred. The advantage is you can hit the stone and pass the guide wire like this. Once you do dilatation, whether in prone or supine, you will finish the inferior calyx. After that, negotiation to the pelvis and upper calyx is more easy with the supine PCL is our observation. That's what we wanted to show. See, the stone is slowly going up. Some amount of stone is coming after breaking automatically with gravity down. Now, after breaking the inferior calyceal part, see, this is the two stones. One is in the pelvis, another is in the upper calyx. When you are breaking, naturally it tries to move up. In this case, when it goes up, it becomes more easy because the stone in the upper calyx will be more posterior. That means from our puncture site, we look down and remove the fragments easily by gravity. So from the lower pole to upper pole migration is not very big problem in supine PCNL. This is a complete upper pole. Stone is sit in the upper pole. Entire upper pole is in view. From the lower pole going to the upper pole is definitely more accessible in supine PCNL is our observation. This is a large stone. Again pushing up. In fact, we can push to the upper calyx so that effective lithotripsy can be done with pneumatic lithotripter. When we do lithotripsy of such large stone burden, chances of migration into the other calyces will be there. If those calyces are multiple and compound, and definitely to increase the SFR, flexible ureteroscope is useful. That is, see, this is the upper pole infundibulum and ability to go into the upper pole completely like this. And moment you go there, the stone is coming out. Very less often triprong is used or biprong is used. Like this, only small fragments which were not floating. This is the last part where we are emptying the upper pole. So entire pelvis and upper pole is collapsed and is in front of you. This is what we wanted to depict. At the end, we thought we finished the case with complete clearance. When we injected the RGP, there was a shadow in the middle calyx which has a narrow infundibulum. And there is the disadvantage of supine PCNL is going into middle calyx from the inferior calyx is difficult. So we used RIRS, the flexible ureteroscopy from below, just above the ampla sheath, and at acute angle the stone was there. Grasped with the forceps, Dakota basket. And this is done by Dr. Soundarya and Hemnath after 1 year of the training. So, like in prone PCNL, supine PCNL also, learning curve is not very steep. And this stone is in front of the nephroscope now. And the stone is removed to the same track, so that less time is spent. Now nephrostogram is complete clearance. All the calyces are inspected. So inferior calyceal stone, if it is pushed into the upper calyx, can be managed in supine PCNL. And if any small fragments migrate into different calyces, ECIRS is helpful. Thank you.